Good morning and welcome to Grand Rounds. The clock in the back of the room is wrong. It's time to start. Today we have a very distinguished speaker, Dr. Kristine Casal. She will be our Pediatric Chief Resident next year, and we'll learn about what bureaucratic headaches are really about, but we'll be very supportive to you. So today, Kristine is going to talk about Kawasaki disease and reviewing current treatment and guidelines.
Thank you. All right. Thanks, Dr. Miller. Also, it's Dr. Miller's last grand round, so I'm happy that she gets to be present in line. Good. So we are going to review current treatment options available and also ones that are up and coming and ones that have been studied in the past. I have no financial disclosures, and these are our objectives for this morning. As you guys know, most of my interest in it is in hospitalist medicine, but while preparing for this talk, I was trying to think of a topic that was not only relevant to inpatient setting, but very much so in the outpatient setting, as well as our specialists who are here. And so we are going to just briefly review the clinical features of both classic and atypical Kawasaki, compare treatment options for primary Kawasaki disease, and review discuss the other potential management for refractory Kawasaki's, and possibly think about a potentially new treatment algorithm based on what we reviewed today. So Alex is going to help me. Everyone, whip out your phones and type in kahoot.it.
Music is coming. Stand by.
Very exciting.
Okay, so this is your PIN number, 1921. And remember, whatever nickname you put in is going to show up on the screen.
Yeah. So we need to figure out who might win this game.
Yes.
There might be a really good prize. So get your competitive on.
And if somebody changed their nickname, that's fine. If you're on the line, you can play as well. There's lots of people. You can use it on your desktop or your phone or your tablet. You can just log into kahoot.it and type in this PIN number here. Somebody's got a fever for more cowbell up here. PIN number is? Oh, the PIN is 1921, 1921. Give it 30 more seconds here. Doc McStuffins, nice. Just so you know, whoever's nickname is up there, if you want to claim your prize, you're going to have to fess up to whatever your nickname is.
This is very true.
All right, let's see if we can get to 20 here. Oh, you lost the person. Everybody playing who wants to play? All right. Here we go.
Good. So I have 19 people.
So you have 19 people. You've got 20 seconds to answer each question, and then we will be moving on. Points will be awarded. So your first question being, what percentage of children with untreated Kawasaki disease will develop coronary artery abnormalities? So if you've never played before, on your phone, tablet, desktop, just click the color shape with the answer that you want, and your answer will be recorded.
Okay. Okay. So up to 20% of children who do not get your standard treatment for Kawasaki will develop coronary artery abnormalities, which is pretty high. And at least 8 out of 17 people got it. Okay? We'll talk about this a little bit further.
All right. So Doc McStuffins is in the lead.
Huh? I know. It counts how fast you're doing it, too.
All right. Next question. Here we go. You want to read it?
Sure. Kawasaki disease commonly occurs in what age group? Oh, well, there you go. Got really competitive.
So you get more points for being quick?
Yeah.
Yes, you do get more points for being quick. Oh, it's still a good split, though.
Oh, okay. So there's a split, but it is more common in the school age group under the ages of 5. So some people picked 6 months, 6 years. That's a little debatable. I kind of tricked some people with that. So.
All right.
This is based on the literature I was reading, but go ahead.
Who is CN? Oh, all right.
Oh.
Beating out Doc McStuffins by just a few here. All right, here we go. Next question.
Which of the following is not a clinical feature of Kawasaki disease? Good job. So remember, you don't have purulent conjunctivitis. You have conjunctival and scleral injection. Okay. Oh. It's like you're on wards or something.
All right. Next question.
A 5-day history of fever is necessary to diagnose Kawasaki. Balls. We'll talk about American Heart Association current criteria for treatment and diagnosis in a little bit, but you should have at least 4.
All right.
Man, all right.
Here we go. Last question.
A diagnosis of incomplete Kawasaki can be made if a patient has fevers with how many characteristic features?
That's a fast answer.
Oh, 3 to 4. So you need to have at least 2 to 3 for incomplete Kawasaki disease, and we will discuss that a little bit later too.
All right, here comes the winner.
Yay! So you get a $20 gas card from Sheet.
Yay! Yay!
Thank you, Alex.
Yep.
All right.
I'll turn it back on.
So it sounds like you do have an idea, or we have heard of Kawasaki's before and kind of have a baseline knowledge of Kawasaki in general. So let's start with a case. We have an 8-month-old previously healthy female who presented with a 3-day history of fever and rash. Her fevers were up to 101, 104, and over the past day and a half, she's not really wanting to eat anything, and she has had a few episodes of non-bilious, non-bloody vomiting, and she has been increasingly irritable for the past 2 days now, Mom says. On physical exam, her vitals are acceptable for age. She was totally fussy throughout the exam. So her heart rate and blood pressure might be a little bit on the high side for her age. Generally, she was irritable, but still somewhat consolable. She was ill-appearing, but non-toxic. And her HENT exam was notable for conjunctival injection without any exudates, as well as an erythematous red tongue with some cracked and dry lips. Her neck had a little bit of shoddy adenopathy. Heart, lungs, and belly all were benign. Her extremities were also warm and well perfused. Her skin, though, she did have this facial flushing and a diffuse erythematous macular rash that almost felt like sandpaper, but it was mostly confined to her trunk and her extremities as well as the diaper area. These are not her, but resembles quite kind of what she looked like. So she had the red lips, the red tongue, scleral injection, and her rash would pretty much looked similar to this, but had more truncal involvement. Her initial workup, her CMP was not terribly impressive. Her chloride was a little bit low. Her bicarb is a little low at 19. Her calculated gap was 19. So we could presume this was probably from her acute vomiting and dehydration. Her liver enzymes that were normal. Her albumin was also normal. Her CBC was not terribly impressive. Her white count at first look is elevated, but based on her age, I think the lower lip or the upper limit would be 17.5. Hemoglobin is a little on the low side, but her platelets are normal, and she does have a bandemia. Her inflammatory markers are elevated with a CRP of 6.2 and an ESR of 59, and her UA did show sterile pyuria with 5 to 10 WBCs and no bacteria. So this isn't a trick question. We all know my topic. So Kawasaki disease, we all know, is a self-limiting febrile vasculitic disorder that has a systemic involvement. The etiology, the true etiology, is still quite unknown. This usually affects your entire body and may affect other vessels such as your celiac, femoral, and iliac arteries. However, in Kawasaki, we're really concerned with the coronary artery involvement. It is considered the leading cause of acquired heart disease in children, and per American Heart Association, it has actually surpassed acute rheumatic fever, which it's not surprising to us. It occurs in younger children under the age of 5 years. Rarely ever does it present beyond school age. It is about 1.5 times higher in boys than girls. And there is a seasonality variability with Kawasaki's. Most commonly we see it during the wintertime here, at least in Roanoke. However, you can also see it during the spring season. In other countries where there's a higher incidence like Japan, Taiwan, they also see this more commonly during the summer months. So there's definitely a varied presentation depending on your location. And in the United States, it accounts for at least 19 out of 100,000 hospitalizations in kids under the age of 5 years. So what is the classic criteria for Kawasaki? So based on, this is per Red Book and American Heart Association guidelines, you need to have a fever of at least 5 days and at least 4 out of 5 of these clinical features. So you have changes in your extremities, so you have your erythema of your palms, soles, which can be quite painful sometimes. You have this polymorphous exanthem, that's the generalized rash, which could look sometimes maybe scarlatiniform, sometimes can even mimic erythema multiforme. And then you have this bilateral conjunctival injection without exudate. So in this picture, it spares your limbus, which is that avascular zone around your iris. So this picture here kind of looked like our case. You have oral mucosal involvement, that's your classic strawberry tongue and cracked lips, and you have a cervical adenopathy. Usually it's unilateral, it's non-suppurative, and it's quite large, up to at least 1.5 centimeters. It's important to remember that these features don't all present at the same time, and it's a continuum. And so typically the eye involvement occurs first with a fever, then you may have the rash 5 days later. But that's why it's very important for a resident medical student to take a very detailed history from parents. And also you have to think of other differential diagnosis if maybe it fits one or two of these clinical features because there are other infectious sources like adenovirus who may present exactly the same way. So what is incomplete Kawasaki? So you have an incomplete Kawasaki if you don't fulfill the classic criteria we just talked about. And you really need to be considering this in patients with fevers for 5 days or more with at least 2 or 3 clinical features that we mentioned, along with supportive lab findings that we'll discuss. And this is actually more common in the younger children, which is why it's more important to have a high clinical suspicion if you have an infant who maybe is 6 to a year of age who presents with at least 5 days of fever and you don't have a known source of their fever. Because as you can imagine, you're not suspecting this, so you have a delay in diagnosis, thus a delay in treatment and management, which then could cause their increased risk for coronary artery abnormalities. So I'm pretty sure the residents and the students are probably very familiar with Red Book and this algorithm for evaluating suspected incomplete KD. So again, you have 5 days of fever with at least 2 or 3 of those clinical criteria. You're going to assess the features that they have, and if you are highly suspecting Kawasaki's, you're going to get labs, and whether or not your inflammatory markers are elevated is where you're going to proceed with your evaluation and management. And I'm going to talk about what does a positive echo mean here in a little bit. So when are labs helpful? Again, labs are useful when you're trying to assess the increase or decrease in likelihood of your patient having Kawasaki disease. Again, they're not specific, but they can support that suspicion, especially if you have at least 2 or 3 of those signs that's suggestive of Kawasaki's. So some of the lab findings you may find with a child who will have incomplete Kawasaki is your elevated WBCs, obviously elevated inflammatory markers. You may have a normocytic, normochromic anemia. Hypoalbuminemia is also seen in some of these patients. Some of these lab findings, though, such as thrombocytosis, may not present until later on in the course. You also have elevated transaminases that could just kind of make you feel a little more strongly about your suspected diagnosis. So what is a positive echo? And so Dr. Miller's going to help me out with this one. A normal echo early on the course is typical and very common, and having a normal echocardiogram does not exclude Kawasaki's, but may help with those patients that you're just kind of on the borderline for. And so we measure the Z-score, which is pretty much the number of standard deviations from the mean. So a normal population will fall within 2 standard deviations below or above the mean. So if their Z-score is less than 2, they have a normal coronary artery dimensions. And so you have a positive echocardiogram if you have a Z-score of at least 2.5 with your left ascending and right coronary arteries, or you have 3 of these suggestive features that I listed here. So either the lack of tapering, decreased LV function, mitral regurg, or a pericardial effusion. And so the handout that I had given had some of those listed as well. Dr. Miller, any comments? Okay, thank you. Okay, so I have a little brain break just to kind of cut it off a little bit. So I have 2 quizzes. How well do you know your pediatric resident? So it's just a matter of who raises their hand first. Alex, help me out from the back. Okay, all right. How many DOs and MDs does our program have? Yes, Dr. Matt. Of each. Okay, let's do of total. Let's do of total. 16, how many DOs though? No? I guess you guys don't know. 6 what?
6 DOs.
Correct. We have 6 DOs and 10 MDs. This is taken from our retreat. We represent at least 13 different med schools, which is kind of neat. Dr. Tiffany, you get a first dibs on picking your candy here in my bag later. Okay, so quick recap of our case. Remember that our patient presented to us at day 3 of illness. We admitted her to continue supportive management and monitor her, knowing that our suspicion for Kawasaki is definitely high. Obviously, she continued to be febrile at day 4 of illness up to 103, and she was just miserable. It was like we were torturing her, even though we weren't doing anything. So now what? Do we just leave her? Do we wait till day 5 of illness of fever? So to treat or not to treat? So the criteria for treatment based on American Heart Association, you can actually diagnose Kawasaki on day 4 of fever, even if you have an absence of full criteria, but may have coronary abnormalities on your echocardiogram. We all know that standard treatment for Kawasaki is high-dose IVIG, at least within 10 days of their fever onset, as well as high-dose aspirin until they're afebrile. So this is our patient's echo, and to just orient everyone, might be hard, but your right coronary artery is right here that pops out, your aorta, your left main, and then we didn't label it here, but your left ascending is right here. So based on the echocardiogram, Dr. Miller's read was noted for a mildly prominent left main and LAD, but her right coronary was normal. There were no aneurysms seen, but because she was on day 4 of fever and her labs were supportive of Kawasaki disease, we went ahead and treated her with IVIG and aspirin with the guidance of Dr. Miller. So did I finally fix her? Did it work? Well, this would be a very short talk. So let's briefly discuss the standard of treatment with IVIG and aspirin. This combination treatment was initially described back in the early 80s. There are no randomized controlled studies of IVIG monotherapy, so just IVIG without aspirin. There was one back in 1983, but it was uncontrolled and had 5 patients, so that was not a very good study at all. The mechanism is not known, but it makes sense. You have a diffuse inflammatory and immune-mediated response, and so if you are suppressing those, then potentially you are treating them. So either decreasing your cytokine or TNF alpha, you're neutralizing your autoantibodies and also modulating your B and T cell functions. Okay. So what is the real lowdown on aspirin? So when we were talking with Dr. Miller, she was kind of indifferent about aspirin, what dose we should start it with. She suggested, she recommended 4 to 50. We started that. We presented it to the hospitalist. They freaked out. So we changed it to 80 to 100. So aspirin has been used to treat Kawasaki for many years. Again, initially during the acute phase, along with IVIG, it acts as an anti-inflammatory effect. It has an anti-inflammatory effect. And later on, during the subacute phase, when they're no longer febrile, it acts more as an antiplatelet. And so, interestingly enough, the practices regarding how much aspirin and how long really varies from country to country and institution to institution. Some do start the high dose until they're afebrile, but some treats them for 14 days total. And in the U.S., we are more used to treating with 80 to 100 mg per kg per day, but in Japan, they only treat with moderate dosing of 30 to 50 mg per kg per day. So I thought that was quite interesting. So aspirin hasn't really shown to play any role or a significant role in reducing the frequency of developing coronary artery abnormalities or IVIG-resistant Kawasaki's. Some studies have shown that you still have persisted elevation of your acute inflammatory markers, and some studies have mentioned your potential side effects with high-dose aspirin because remember that aspirin side effects are dose-related. So this was published in the Journal of Pediatrics, which assessed the prevalence of coronary artery disease in patients who were treated with IVIG, with aspirin, as well as aspirin monotherapy. This was a meta-analysis of 6 randomized controlled studies in the U.S. and Japan. And what they found was in patients who were treated with moderate dosing of aspirin, there was a 26% prevalence of coronary artery abnormalities versus those in high dose was about 23. Sorry, this is supposed to be 100. However, they did see a decrease in the prevalence on those who were treated with IVIG of various dosing. So there were studies that treated Kawasaki's with less than 2 grams per kilo of IVIG, and those had a significantly higher prevalence of coronary artery abnormalities based on the lower doses of IVIG. So they really found that the prevalence of coronary artery abnormalities was inversely related to the dose of IVIG, but independent of the aspirin dose. So that was interesting as well. And you have to think about the side effects that come along with your high-dose aspirin. And I remember Dr. Miller was saying she's kind of breathing really fast in that room. So you got to think of your metabolic acidosis that you may not be seeing at all. Yes, Dr. Howell.
That study, they didn't do monotherapy with only IVIG.
They did not. No. Mm-hmm. With yes. Yes. Yes.
Not using
will.
Really, whether we should use it or not.
Right. Yes. Yes. They did not. No. Not that ones that I've seen, at least. Okay. I trust you.
Will you repeat that for the people?
Oh.
They haven't done any monotherapy studies?
No.
They have not done any monotherapy studies of IVIG comparing it to aspirin alone. Is that good? Okay. I'm sorry. Okay. And so what about the steroid debate? Okay. So what about steroid plus IVIG and aspirin, which is your standard therapy for treating Kawasaki? So Newberger, who apparently Dr. Miller knows and has met, is a very nice lady, published this article in New England Journal of Medicine. It was a randomized, double-blinded, placebo-controlled trial. It was a 2-year study of 199 children who initially were randomized to receive IV prednisolone versus placebo, and then thereafter was given the standard treatment. And what they found was that the steroid therapy did not improve any coronary outcomes post-treatment during their follow-up at weeks 1 or 5. Acutely, it did shorten hospitalization by a day or 2, and it did normalize your acute phase reactants, but that's almost to be expected with your post-steroid therapy. And so basically her study did not find any support for adding post-IV steroids to our conventional treatment of IVIG and aspirin with Kawasaki. Right, right. And that was what, when I was speaking with Dr. Burbridge, it makes them feel better. We are decreasing their hospital stay. I do have to note, though, but the total number of days in the hospital, including readmission, was the same from that study. So those kids who were, their total number.
Talking high dose versus moderate dose aspirin, right?
No, I'm talking steroids.
Oh, okay.
Steroids, yeah. By like a day from when they were admitted, but their total inpatient hospitalization numbers of days in the hospital were the same. So can this then prevent any coronary artery development? We can't really say it's good for treatment, for primary treatment, but can it help with preventing the coronary artery abnormalities that we are most concerned with? So this meta-analysis reviewed 9 clinical studies that were relevant to IVIG and steroid therapy, and what they found was fewer patients who received the combo treatment of steroids and IVIG and aspirin experienced less coronary artery abnormalities versus standard treatment, which was kind of interesting to me. But when they combined the outcomes of the studies, each study was different. You have intrinsic variabilities and study designs. There were a lot of biases, so they had a lot of weakness in this study, in that they really needed more randomized controlled studies on a larger scale, maybe internationally, to really assess whether or not steroids can decrease your risk for coronary artery abnormalities. So it could, but you need better studies. Questions on that? So steroids, not a fan. Okay, last brain break. How many children does our program have? That's why you guys got, yes. Dr. Ahmad. Nope, yes. Hey, you're winning all my. So we have the Hendersons and the Dodds and the Bowles. But let's not forget all our fur kids that help support us through residency. Okay.
In the middle there, if you didn't see that.
And so we're not quite done yet. So remember, we treated our patient, back to our patient, we treated her with IVIG and aspirin. But of course, at the 35th and a half hour, she spiked the fever up to 103. And so based on that, she has refractory Kawasaki disease. And so we decided to go ahead and treat her for second IVIG infusion. And she finally effervesced that day and was discharged 2 days after her second IVIG infusion. Okay, so we talked about primary therapy. What about, primary therapy, what about those who are resistant for your initial IVIG treatment? So up to 15%, which is a pretty high percentage of patients getting the standard treatment of IVIG and aspirin will have recurrence or persistence of fever. It's associated, refractory Kawasaki is associated with a higher incidence of coronary artery abnormalities, which makes sense. You're not really treating them. And so it's very likely that in these patients you may need a second IVIG to really treat them. So there are some very cool potential treatment options that are currently being studied. Steroids is still hovering all over us, but there are biologics like Infliximab and etanercept that are currently still under investigation. There are other immunosuppressant as well as chemotherapeutic drugs that has been studied, and even plasma exchange. So we'll briefly go over that. This is a very large table of the novel therapies for refractory Kawasaki. So like I mentioned, your Infliximab, etanercept, you have your various types of steroids, methylprednisolone, dexamethasone, and then you have your chemotherapeutic agents like methotrexate, cyclosporin, and cyclophosphamide, and again, plasma exchange for treatment of refractory Kawasaki. So we already gathered that there's a questionable role in treating Kawasaki, primary Kawasaki, with steroids. How about in someone who's resistant to your IVIG? So Hashino published this in 2001, and this was the first study that really assessed the efficacy as well as the safety of steroids as a treatment for IVIG-resistant Kawasaki. This consisted of 262 patients. About 13 of those did not respond with your initial IVIG treatment. Half of those needed a second dose, and then another half of those people needed a third treatment, and that was when they either decided to do a third IVIG or steroid. And what they found that, again, acutely, it did shorten the duration of their fever from 1.4 days versus 4.8. You did have the associated lower medical costs. I mean, steroids is way cheaper than IVIG. But what they found during their follow-up was that there was an associated transient coronary artery dilation with the steroid pulse therapy. Now, why this happened, they didn't mention, but they had some postulations. Maybe steroids had an effect with reconstructing the vessels, but after their long-term follow-up at week 4 or 5, their coronary arteries were back to baseline before they even discharged them from the study. So Hashino's study gathered that maybe a steroid might be useful in someone who has resistant Kawasaki, especially if they have prolonged fevers, but you really need to consider the potential side effects, not knowing what the clinical significance of having a transient dilation of your coronaries. So they need to be closely monitored if we're going to do this. And for the biologics, Infliximab, this was published in 2014 in Lancet. This was a phase 3 randomized double-blinded placebo-controlled trial. And what they did was they added Infliximab to the standard therapy. And they found that, again, you have less febrile days, you have greater reductions of your acute inflammatory markers, and there was a 2-fold greater decrease in the mean Z-score of the coronaries earlier in the treatment course, so at the end of their study. However, after week 4 and 5 of their follow-up, there wasn't a significant difference between the two groups anyway. And I believe this was to Children's Hospital in the U.S. with a total number of just 196 patients. So adding Infliximab to primary treatment of Kawasaki didn't really reduce the rate of resistance of IVIG. But again, you have this acute improvement of the overall clinical improvement, decrease, less febrile days. Overall, they probably feel a little better, and so maybe it's something to consider. There are other studies that have been investigated that might be a potential treatment option. One of them is plasma exchange, which makes sense. If you initiated this early on their illness, then you may reduce coronary artery abnormalities. And so it makes sense. You're removing all the cytokines and you're targeting your inflammatory pathways, but still that needs to be studied. Again, the chemotherapeutic drugs may have some role with treating refractory Kawasaki, but then again, you have to be mindful of the toxic effects. Is it worth having them go through chemotherapy and be immunosuppressed? And again, it makes sense how these work because you're really targeting your inflammatory and immune pathways. So last thoughts. Based on what we reviewed today, maybe someone might be inspired to to look over all of the Kawasaki we see here in the Roanoke Valley. At least from when I started at the first year, I'm seeing them more frequently. It's as if we have 1 or 2 monthly, if not one or 2 weekly without, it has a season variability. I think this winter we saw a lot. And so the first thing that I thought of was, aspirin, what should we do about that? Are we really, I know we're hesitant to treat with moderate dosing since we're very much used to treating with high dose, but should we maybe look more into that? And because 15% of those patients who get your initial IVIG do fail treatment, at what point do we then consider other treatment options? Again, we still have to kind of dig a little deeper onto that and look up more studies and bigger studies. And obviously, each treatment option, you have to outweigh your risk and your benefits along with how it might impact your managing your patients. Questions? Resources?
There's a question in the back here online. Let me see if I can ask it correctly. All right. So it's on the subject of getting echoes. Okay, so I think the original question was, do you normally have one normal echo in this process? And then it was probably not, especially if it's refractory, but how often do you do future echoes? So I guess the question is, how often are you doing echoes in these kids? Anybody want to take a stab at that?
It depends. We know that the aneurysms don't really come until around day 10 or 14. So certainly we want to bring them back. And after about the second week, if they're really afebrile, feeling better and bouncing back and their coronaries look normal, we're pretty comfortable that they're probably going to be okay. However, we do still see, it's been our practice to see those patients with normal appearing coronaries about 6 months later, and we'll look again. If they had a pretty tough course and were pretty refractory, it may be shorter than that, just to make sure that there's not something going on that we can't see. We follow, most of these patients, we do follow intermittently lifelong. We want to make sure that they get their lipids screened when they're 11 or older because there's some suggestions or some worry that they may be more susceptible to coronary artery disease, although with completely normal coronaries, the papers have really showed that they don't have increased risk of coronary artery disease when they're older. So if they've had small aneurysms, we probably would follow them when they became normal at least every other year or so. And then with the giant aneurysms, that's a whole different ballgame. Speaking of giant aneurysms, do you have that email that I sent you with a picture? I sent Kristine.
Any other questions in the room? No questions? All right, I can unmute the phones here real fast. We have lots of people online.
The conference is now in talk mode.
Okay, if you're on the line and you have a question, you can ask it now. If you do not have a question, just please mute your phone so you don't hear conversations or background noise. So any questions for the presenter? Somebody got nervous and muted their phone. Okay. Any other questions in the room? All right. Thank you very much. If you are still on the line and you do have a question, you can always email me at outreach@carillionclinic.org, and I'd be happy to get them to the presenter. With that, we're going to go ahead and disconnect the phone lines now. Thank you all very much for joining us.